So, hi everyone. Thanks for joining us today for the CPE Speaker Series presentation, which is co-hosted by OPEN, the Ontario Pharmacist Evidence Network. For those of you who don't know, my name is Annalise Smeathers. I usually help Lisa Dolovich coordinate the CPE Speaker Series this year. Today we have Dr. Sherilyn Houle speaking with us today. Sherilyn's an assistant professor at the University of Waterloo. And her presentation today will focus on the present and future opportunities to expand scope of practice for pharmacists across Canada in providing travel health services. So Sherilyn's going to speak with us for about half an hour, and then we'll have a short discussion by Dr. Sandra Mejia from here at the University of Toronto. She's the Interim Director of Professional Programs and an Assistant Professor. She'll speak for about 5 to 10 minutes just on the content of Sherilyn's presentation. And then we'll open up the floor to question and answer from both people in the room with us here and then people who are joining us remotely or virtually online. So if you are joining us from online, just a reminder that you can type your questions into the question pane in the GoToWebinar panel, and then I'll moderate back and forth after the presentations to do that. So thank you. I'll pass it over to Sherilyn with that.
All right, thank you for the lovely introduction. Like she said, I'll take about somewhere between 20 minutes and half an hour to kind of go over what we know so far about pharmacists as travel healthcare providers and some ideas about where some of the future opportunities can come in regards to research and practice. So in the next little bit of time that we have together, I have 3 really brief points that I hope to cover. So first, I'd like to talk about the different scopes of practice that are available to pharmacists across the country with a specific focus on their role related to travel health. Also summarize what we know so far, like I said, about pharmacists as travel healthcare providers, and then finish up with those opportunities for growth in practice. So going on to the first one, which is looking at scopes of practice. So I'm sure everyone is well familiar with the CPHA scope of practice chart that has the series of checklists for every single item that pharmacists in each province can do. What I've done is I have distilled that down to a map here, and I've also tailored it to be only relevant to activities that are most impactful with regard to performing pre-travel consultations, vaccinations, things of that nature. So I'm sure everyone is well aware that our 3 northern territories are unfortunately at the beginning stages of any type of expanded scope type of practice, so they don't have any prescribing or injecting in place at the moment. The majority of provinces, so you'll notice BC, Saskatchewan, Ontario, Newfoundland, and PEI, if you can see it, small little island on the map there. Those provinces right now allow for immunizing authority, but not yet prescribing authority. Of course, there are options in some of those provinces for delegated prescribing, collaborative practice prescribing, something like that, where it's based on a one-on-one relationship with the prescriber who delegates that activity to the pharmacist for travel consultations. When we look at the provinces that are a little bit farther along that spectrum towards full scope, of course, Alberta is the world leader in that area. So pharmacists there, any pharmacist with injection authorization can administer any vaccine. So that includes, routine vaccines if they're able to get them or have the patient pay for them, travel vaccines, as well as any injectable medications. And they also have the additional prescribing authorization program, which does allow pharmacists who have that designation to potentially prescribe pretty much any medication that can also be used for a travel purpose. Of course, that's going to be dependent on their personal level of knowledge and competence in that area, and the discretion really is left to the pharmacist to decide if they feel comfortable prescribing for that or not. And then somewhere kind of in the middle of those is the extended practice pharmacist legislation in Manitoba. That one there allows pharmacists to obtain status as an extended practice pharmacist if they meet 3 conditions. So they have to have their certificate in travel health from the International Society of Travel Medicine. That's an exam similar to the certified diabetes educator, certified respiratory educator, that type of exam that provides that credential. So they have to have that credential in place. They have to have at least 1,000 hours of patient care experience over the past 2 years, so achievable for most pharmacists probably in that area. And then the final criterion, which I think is probably the most limiting to them, is that in order to obtain this designation, they not only have to have a letter of support from collaborating healthcare professionals that they work with on a regular basis, so physicians, nurses, things of that nature, There's also wording in the legislation saying that these pharmacists have to have, and I quote, access to the same diagnostic and health information as these other colleagues that they're providing care and collaboration with. So as you can imagine, when we consider the challenges with interconnectivity of electronic health records and things like that, I think that really does create a bit of a barrier for some pharmacists that might want to get that designation and are certainly trained and qualified to, but maybe don't meet that final criterion. If they do have that in place, then they do have essentially a delegated form of prescribing where they can issue those orders. And New Brunswick is probably the most complicated of all of them in that regard. So there's travel-related full scope activities that all pharmacists there can have, and there's some that are limited only to those with their certificate in travel health. So all pharmacists can do some limited drug prescribing when it comes to travel related indications. So they can prescribe therapies for traveler's diarrhea and malaria specifically. So that would include antibiotics for traveler's diarrhea. Maybe if they decide that the oral cholera vaccine is relevant for prevention of cholera, they could prescribe that, and they can prescribe antimalarials. They can't prescribe for things such as altitude illness, motion sickness, anything else like that that might require a prescription. So a little bit restrictive, but it does capture at least the most common issue, which is traveler's diarrhea for sure. And it also allows for vaccine administration for the most part, and some vaccines they can administer without a prescription from a physician as well. So all pharmacists can prescribe the hepatitis vaccines. So this makes it really easy for pharmacists in that province to provide care for travelers to the Caribbean, for example, where maybe all they need is that hepatitis protection and that traveler's diarrhea protection. Those pharmacists that have their certificate in travel health can utilize that certificate to get an even more expanded role with regard to prescribing vaccines. So only those pharmacists are able to prescribe vaccines against tick encephalitis, which is a bit odd considering we don't have it in Canada, but it's in the legislation, I guess, in case it ever does become available. They can also prescribe the Japanese encephalitis vaccine, the rabies vaccine, typhoid, and yellow fever. And then again, for all of these practitioners, regardless of whether they have their certificate or not, there's the option of a collaborative practice prescribing agreement as well, which I guess can pick up for where the existing legislation is maybe a little bit incomplete. So as you can see, a huge amount of variation across the province, a huge amount of confusion potentially. And then just to go into the ones that are shaded, sort of partially shaded in yellow and partially shaded in green. So Quebec so far does not have immunizing authority. I hear it's in the pipeline and coming very soon, but they do have prescribing authority against conditions not requiring a diagnosis. So when I read into that, I think, well, it must be eligible for traveler's diarrhea, malaria, altitude illness, all of those things, because they're preventative rather than based on a diagnosis. So it should fit within that criteria. I'm not familiar with many pharmacists using it, but that's theoretically how it could apply. And then when we look at Nova Scotia, they have full authority, but only related to vaccines, not related to any drug therapy. So a huge mishmash across the country with regards to what pharmacists can do. Now, considering that we're speaking with an Ontario audience here for the most part, we'll go over what's most relevant to us here in this province. So of course, any pharmacist can provide OTC related travel advice. So advice on OTC medications for traveler's diarrhea, for sun protection, insect protection, all of that type of thing. That's certainly within everyone's scope. Adapting an existing prescription, except for therapeutic substitution. And I think this is a potential limitation when it comes to traveler's diarrhea antibiotics, for example, because we still do see a lot of practitioners issue prescriptions for ciprofloxacin for this. The current guidelines and evidence to date is showing there's a lot of resistance against that. And so actually most of the patients should be getting azithromycin. So a community pharmacist right now wouldn't be able to change that active ingredient if they do receive that prescription for Cipro, but they could alter the dose or the duration or anything else like that. A travel consultation is not a protected activity, so sitting down with the patient, determining their individual risk level and determining some recommendations for therapy is certainly in the scope of all pharmacists to do, as well as administering the vaccines that are relevant for that patient's travel. We do have challenges with administering routine vaccines, especially with the measles outbreaks going on right now. Almost all of them in North America, to my understanding, have been imported from travelers. So at the clinic I work at anyways, we do consider MMR to pretty much be a required travel vaccine because measles is so contagious and people are going into an international airport where the chance of contracting it is really so high. But unfortunately right now we don't have access to that here in Ontario to administer. and we don't have the opportunity to really issue any prescriptions. So we're not at the stage of New Brunswick where they can give prescriptions for travelers' diarrhea. We're really at the stage of needing a collaborative delegated prescribing to do any of that. And where this also becomes relevant is when we look at the travel vaccines that pharmacists in Ontario can administer. So in addition to the influenza vaccine, there's 12 other illnesses here that pharmacists in Ontario can vaccinate. You'll note that many of them require a prescription still, so that lack of prescribing authorization does create a bit of a barrier and a bit of a lack of seamlessness in care, I guess you can say, from the patient's perspective. And then here I've shaded in the ones that are mainly considered travel vaccines in orange. So of course, most of the vaccines that a traveler might need that a pharmacist can determine through their travel consultation would have to be ordered by a physician or a nurse practitioner, which does create that delay in access, certainly. For anybody that's wanting some additional information on what kind of all professionals in Canada are doing, there is a very recent paper that was published in the Journal of Travel Medicine at the end of last year, where they kind of looked at the landscape of travel health services across the province and across professions. Interestingly, anyone who has read this paper note that they talk quite a bit about pharmacists because we're the fastest growing demographic in this area across Canada, but yet didn't invite a single pharmacist to be an author on the paper, which is disappointing, but hopefully I can break that mold and get into that circle to make sure that we have pharmacists talking about pharmacists when we're looking at scope of practice and readiness to provide this level of care. So I've gone over the scopes of practice across the country, and now we'll get into kind of the evidence and what we know so far about pharmacists in this role. So if we were to do a complete systematic review of all the literature, it is all right here on one slide. So we don't have a lot. We have 9 papers altogether that talk about pharmacists as travel healthcare providers. Interestingly, it's also only in the US and in Canada. So we have lots of activity in this area, particularly in the UK. There's lots of prescribing pharmacists in the UK that do travel consults as well, but we don't yet have papers coming out of there talking about their role. So really mostly a North American phenomenon at this moment. And those of you will note that there's a familiar name on pretty much all of the publications from Canada. So I would argue it's even newer here in Canada to be talking about pharmacists as travel healthcare providers. So if we look at the very first study that was done, it was done in 2004. So we're about 15 years into having this be on really anybody's radar. And this study looked at the effectiveness of a pharmacist-run travel clinic service within a managed care organization in the States. This was a telepharmacy service, so there was no direct face-to-face interaction with the patient. They were incredibly high volume. So they performed almost 10,000 consults a year, and they had 3 full-time pharmacists doing it. So about 3,500 consults a year per pharmacist. So way more high volume than most other healthcare providers, regardless of their profession, and especially community pharmacists that are relatively new to this. They found that the duration of the consultation was 10 to 30 minutes. That's quite consistent across most of the studies that we're seeing. And they estimated a cost 15 years ago of about $45 to $50 US. I would argue that's looking like a lot of the fees that we're seeing charged in Canada, even without the exchange rate, and 15 years later. So there might be some room to re-examine what the current market value of that service is here. They did have co-located physicians that could co-sign the prescription, so that really overcame the prescribing barrier that a lot of them faced. But because these consults were done over the phone, they couldn't provide the medications or the vaccines in person at the time. So the patient did have to go to another healthcare professional to receive those services. So created a little bit of a disconnect, but at least it did allow them to issue the prescriptions. And what I think is really interesting is the final 2 points that I pulled out of their results. So like I mentioned, travel consultation is not only to talk about travel vaccines, but to look at a person's entire vaccination status. And this helps to defend my position in that regard. So they found that almost 2/3 of patients that called in for a travel consult were actually unimmunized or under-immunized against routine conditions that they could otherwise be vaccinated against, so such as pneumococcal disease. So I think that when we have that opportunity to do a full assessment and we're looking at their vaccines anyway, it's a perfect time to get all of the vaccines out of the way. And perhaps even more relevant to us when we're trying to make an argument for the cost effectiveness of pharmacist-based care, they did a retrospective chart review where they compared recommendations provided to patients by a nurse-led clinic where the nurses didn't have any additional training in travel medicine, but they did kind of have protocol-based care in place, and then this pharmacist-led telepharmacy service. When they looked at the vaccinations and compared what was recommended versus what was actually required for the patient's exact itinerary, they found that the pharmacist-led clinic could save about $47,000 a year just in unnecessary vaccinations alone. So the pharmacists were doing a better job at tailoring their recommendations and really only recommending things that were required. For those of you wondering, the unnecessary vaccinations would include things like Hep A or typhoid for people going to other developed countries. So people going to Australia don't need those. They aren't issues there. As well as people recommending Japanese encephalitis for travel to Asia, even though they were going for a short time to an urban area and unlikely to be bitten by that mosquito. So quite significant cost savings that were recognizable from that pharmacist-led service. The next study that I'd like to review is the one by Durham that was done in 2011. Now this one here was done to kind of answer the question that's been coming out that, well, family physicians provide travel consults, what benefit would adding pharmacists to this mix add? And so what they did is they did a chart review as well of patients who were cared for by primary care providers, again, who weren't specialists in travel medicine, and those could be physicians, physician assistants, and nurse practitioners, and they compared them to pharmacists providing care who did have some additional specialization in travel medicine, and then just like the previous study, compared the recommendations against existing guidelines. And here's a number of the main outcomes that they found. So there are obviously some scenarios where you don't want to undertreat and you don't want to overtreat. And this study looked at both of those perspectives. And they did that for traveler's diarrhea, for malaria, and for vaccines. So you will note that the not ordered when indicated is obviously a negative, and you want that number to be lower, whereas ordered when not indicated is also a negative thing, and you want that to be lower. So the lower number in each of those two columns next to it is the preferred outcome. We see very consistently for traveler's diarrhea antibiotics, for antimalarials, and for vaccines that the pharmacists had statistically significantly better prescribing and recommendations in alignment with the guidelines and current travel needs of that patient. The bottom two rows talk about, okay, the recommendation may have been appropriate, but how many of those patients actually received what was ultimately recommended for them? And so obviously a higher number for each of these is better. And we saw statistically significant benefits for pharmacists' care for receiving a medication when ordered. So for people actually getting their antimalarial dispensed even when it was ordered, we saw higher rates of that in the pharmacist group, and also a higher mean number of recommended vaccines actually being received as well. So a very positive study saying that this is a role that pharmacists can play and can do so quite effectively compared to existing care providers in this area. The next two studies that I will go over really briefly are the two that were based in community pharmacies. They had similar outcomes, which makes them easy to compare. So they both involve pharmacists that had their certificate in travel health. The difference is the type of setting. So the Hess study was done in an independent community pharmacy where they did have a collaborative practice protocol in place that allowed prescribing. And then the Trans study below it was done in a supermarket chain, but they didn't have that collaborative practice in place. So they needed prescriptions to be achieved for those. So we saw really variable rates and acceptance for different vaccines that were recommended. This is typical. We see this all the time in my clinic because a lot of these vaccines are not required. They're recommended, and they're recommended based on a patient's individual level of risk. So that patient is going to consider their level of risk as well as the cost of the vaccines in deciding if they need it. So we see a lot of variation in what people decide their level of risk is that they're willing to take. So you'll note a huge difference in between the acceptance rates for each of the vaccines between the two studies. But what I would like to highlight when we're interpreting this is that the study by Hess at the top did not look at routine immunizations at all. They only looked at acceptance rates for travel vaccines, whereas the Tran paper looked at both travel vaccines and recommended routine vaccines together. And they found that the rates for acceptance for the routine vaccines were a lot lower than for the travel vaccines, and that pulled down the ultimate acceptance rate. So just something to keep in mind there. Acceptance rates for travel vaccines seems to be a lot higher than for routine vaccines. And overall satisfaction very high across both services, into the 90% for patients being satisfied with the service. So it is something that pharmacists or patients do appreciate being done by pharmacists. We do have some work to do with that shared decision making potentially, and making sure that the patients declining vaccines are really doing it in an informed manner. And then digging into the Canadian research a little bit. So the very first paper that I did was with a colleague, Christina Bascom out of Alberta, who is she operates a full service travel clinic and is a pharmacist with prescribing and injecting authorization. Now, she did this study before she had that in place when she was doing her training, and she just wanted to know what's the current landscape of community pharmacist readiness to provide this service and practice. So she distributed a survey to all the community pharmacists working in the chain that she worked for at the time. And not surprisingly, so about 7 in 10 of them said they provide some form of travel advice at least once a month. This might not be super specific, but we included anything. So if people wanted advice on bug repellent, motion sickness, nausea, any of that kind of stuff, it was all eligible to be counted. And then what we did was we developed 2 cases that each had 3 questions on them to assess their level of knowledge in particular topic areas. And what we did is we asked the pharmacist to answer those questions and decide on that case what their recommendation would be without looking at any references. So perhaps not realistic in practice where people would be looking to references, but we wanted to know what they knew in their head confidently without having those references in place. We had a 27% correct answer rate, I guess, across all of those studies, but about 2/3 felt confident that if they needed to look something up, they'd at least know where to get it. And I guess reflecting that, only about 1 in 5 said they felt highly confident providing travel health advice. So even just a couple of years ago, there were still quite a few pharmacists who had to provide advice in practice, but weren't entirely sure that what they were doing was with confidence. Looking at the levels of knowledge by topic, not surprisingly, people felt comfortable doing a pre-travel assessment, and they felt comfortable dealing with traveler's diarrhea because they probably see that all the time. But then once we got into the more specific travel-related recommendations, that's where the confidence really came down. So not necessarily surprising, but it did show us the areas that we need to definitely address. So once this pharmacist did open up her own clinic and did provide that full service clinic, we wanted to see what she was seeing in her practice and what kind of recommendations she was providing. So we did data collection on slightly over 100 patients who came to her clinic, and we found that of those, 87% had some type of complicating factor that made them perhaps more difficult to be managed by a general practitioner, a general community pharmacist practitioner as well. So 62% of them went to a bit of a more complex destination, so to Asia, to Africa, to South America. About 1 in 4 or 1 in 5 of them were going for more than 3 weeks, which increases their risk of exposure, and about the same proportion had to travel to a high altitude or malaria region. So she did have a very specialized practice, but again, we think this isn't necessarily a huge difference from a lot of the patients who would initially at least present at a community pharmacy with some questions. She had a pretty high rate of acceptance for her vaccinations as well. So 79% of those that she recommended had the first dose given in the clinic. So without any delay, without the patient going home to think about it, they got it right at the time. Again, very highly satisfied patients for those that did respond to the survey. And what we did is we surveyed them after they returned from their travel and not necessarily right after they received the consultation. Because obviously a person can be very satisfied with a consultation, but if they go abroad and they get sick and they don't know what to do, then that consultation really hasn't served its purpose. So after they returned is when we got this 95% satisfaction rate. So obviously the consult was doing what it was supposed to be doing. And out of those, about 15 had some type of illness, with GI illness being the most common, everything else being very, very rare for the most part. And I was especially happy to see that all but 1 of those felt prepared to manage their illness abroad. So if something did happen, they knew when to consult a physician, they knew when to take their medication, they knew what to do. So very, very positive results from her study. Just earlier this year, myself and Dean Urick out of U of A looked at some data in Alberta, because we were wondering if the availability of pharmacists as the ones giving the injection would increase adherence to multiple dose vaccine series. So some of these vaccines require 2 or 3 doses in order to be effective, and we hypothesized that if there's more convenience of being able to go to a pharmacy to get those remainder of the doses, that our patients would be more likely to actually receive them. So below here is a chart of what we found. So the gray vertical bars looks at the proportion of pharmacists in Alberta at that time for that particular year who were authorized to give injections. So we saw an exponential growth since it was first introduced back in 2008 up until 2016. And then each of the lines above that is an individual vaccine product. So for example, the line at the top with the black circles is hepatitis A. The next one just below it with the squares is hepatitis B. And we also looked at the combination vaccine of Hep A and B, Japanese encephalitis, and rabies as being other travel vaccines needing multiple doses. What we found was statistically significant relationships between the availability of pharmacist immunizers and completion of the vaccine series, but it wasn't very large, that magnitude of effect. So of course we're looking at, in some cases, 25,000 patients, right? So we have a large sample size. We did see statistical significance, but clinically it didn't really translate to glowing results. So essentially, if we looked at hepatitis A, we had 24,000 patients who initiated that vaccine over the study period, and out of those, 75 more completed their series than without. So it's better than nothing. Of course, we want our patients to be completing their series, but there's still room to grow there. I think there's room for improvement in our reminder systems that we have for patients. So encouraging and a positive trend, but I'd like to see that effect size get even higher for sure. Moving on to the most recent work that we just did, which was specific in Ontario, we wanted to know how much the change in scope expansion that occurred back in December 2 years ago has had on actual practice. So that's when the scope was expanded from only influenza vaccine to all of the additional travel vaccines. And so we asked pharmacists what they were doing before that, the legislative change versus after, and this is what you see on this map. So a lot more pre-travel consults being performed. We saw a lot more people, well, not a lot more, but you know, a growth for sure in people getting medical directives to prescribe vaccines or to prescribe oral vaccines. And of course, vaccine administration within scope went up because that is what the legislation intended to improve. But it did show some trickle down effect to other areas of travel medicine care. The facilitators that the pharmacists wanted to see to encourage greater uptake were, again, nothing surprising. People felt they lacked confidence in their knowledge level in travel medicine. The prescribing was a bit of a barrier as well, and they wanted patients to be more aware of what they could do for the most part. So nothing necessarily, you know, new and earth-shattering out of there, but again, I think encouraging that this is showing pharmacists have an interest in it, maybe just need a bit more support to actually get there. And then finally, looking at all of this from a financial perspective, perhaps even more relevant now that there's been the meds check cuts and all of that type of thing, is looking at the financial feasibility of these services. So the good news is for a community pharmacy providing this service is that it's untouchable by the government, is how I heard one pharmacist say it. It's billed for on a cash basis directly to the patient, so it's something that really can be charged at the market value, you know, that type of thing. So what I did is I took the recommendations that were prescribed by my colleague in Alberta for her 100 patients and just costed out what kind of revenue that would generate for a pharmacy if they were to do that consultation. So we found mean revenues across the board for, if we looked at all consultations to all locations, of about $132 and about $110 for our less complicated travelers to Mexico and Caribbean area. And what this included was the consultation fee, which we ranged from $45 to $60, which is what that clinic charged, as well as $20 for an injection administration fee and a provincial average dispensing fee of $9.62 per script. This did exclude any markups on the prescription and the OTC drugs. So of course, these numbers are actually even higher in reality, but they did not include expenses. So that isn't necessarily the take-home income after expenses, but rather the revenue specifically that is possible. So we've gone through the first two items here, and now I just want to conclude with a couple opportunities for growth and practice in this area. So some next steps in terms of some of the research that I'm doing here, at least, we're currently wrapping up a curricular review to look at what our pharmacy programs in Canada are teaching our students related to travel type of topics. So we're currently wrapping that up. We're seeing a fair amount of variation across provinces, but overall, I think if you were to ask a university, do you teach your students travel medicine? They would say no. But if you look at each individual item that constitutes knowledge in that topic, a lot of them are being covered either within the injections training curriculum, within infectious diseases, or within self-care. So a lot of this information is there. It's just not necessarily being packaged as being travel related knowledge. We're also working on a triage tool to allow community pharmacies to quite quickly screen who they can probably manage on their own. That's kind of lower complexity, lower level of risk, and who should be referred onward, as well as looking at some different models to make that travel consultation most efficient. Obviously, it needs to be something that's cost neutral, if not revenue generating. So the more efficient it can be, the better from the pharmacy's perspective as well. In terms of practice opportunities, I would love to see us get the ability to give publicly funded routine immunizations, especially MMR right now with our current measles outbreaks going on, as well as explore perhaps maybe in the other provinces for now, but hopefully eventually in Ontario, prescribing for the low risk travel. So hepatitis A and B vaccines and travelers diarrhea antibiotics specifically. Of course, I have to acknowledge the other people who worked with me on making those published papers a reality, as well as financial support from OPEN, from the Canadian Foundation for Pharmacy, and a grant from the International Society of Travel Medicine. So I've got references there in case anybody wants to look them up after the talk, for example, and then I'm happy to take questions after we have some comments from Sandra.
Thanks so much, Sherilyn. That was an absolutely wonderful presentation. I think if we can hold questions, if you want to start generating them in your head, and then you can type them online, but we'll just switch over to Sandra now for 5 or 10 minutes just to provide some discussion.
Okay, thank you very much, Sherilyn, for this very informative presentation on travel health from a pharmacist perspective. One of the things that struck me as you were speaking is that I would like to hear more about your practice, and we hadn't had a chance to talk about this, but can you please tell us a little bit about your practice before we delve back into the evidence?
Oh, sure, happy to. So last fall, I wrote my certificate in travel health exam for my STM and passed it. For anybody who's thinking about it, it's a really challenging exam. It definitely needs some studying, but it is doable and is a worthwhile thing to do. So I wrote that exam to really solidify my knowledge in the area. And then in January, so relatively recently, I started working next door to us, actually, at the School of Pharmacy. There's the Center for Family Medicine Family Health team, and 2 of the physicians there have an interest in travel health and actually run a travel clinic for any of the family health team patients that are traveling. And so I'm now part of that practice. So I spend my Wednesday afternoons in clinic doing travel consultations, I wouldn't call it delegated prescribing, but pretty much whatever I recommend gets the rubber stamp from from the physician. And then we do have, right now, all of the injections are done by a nurse, and the travel consults are either done by the nurse or by myself, with the docs there to kind of review the recommendations and sign off on them at the end.
Great, thank you very much. That's really interesting. So you're at this point in time, the injections are done collaboratively with a nurse in the clinic.
Yes.
Based on the evidence that you provided, what do you think is the greatest barrier to pharmacists' uptake to this, and what can we do as educators to help facilitate this?
Yeah, that's a great question. So I think there's some systemic issues that are going to be a lot harder to overcome and is kind of outside of our scope as educators. So of course the prescribing piece and the disjointedness that creates is certainly going to be a barrier that hangs up a lot of innovation going forward. But certainly we do see the confidence with their knowledge to be a barrier. So whether that is an actual lack of knowledge or a lack of confidence in that knowledge, I think is a great discussion point. I would argue it's probably the latter. Like we've seen when we did our curricular review, a lot of pharmacists are being taught this. They just probably aren't recognizing that they're being taught it. And so I think there's room for us as educators to improve on couching that knowledge, that you already have a lot of this knowledge. It's just a matter of applying it in a different scenario. I also think that where we see a lot of people, and these are a lot of the questions that I tend to get from people in practice, is, okay, I have all of this knowledge. I know which anti-malarial drugs are out there. I know which vaccines are a good idea to recommend, but how do I do the actual consult? right? How do I sit down with a patient, collect the information that I need from them, really distill it down in my head to their actual levels of risk and make those recommendations. So it almost seems like the first aspect of that process is where we need to be improving the most as educators. I think the knowledge is there. The application of that knowledge is where we're really struggling. And that's in our curricular review. It's also the area that seemed to have the least amount of teaching time dedicated to it. So very few programs are actually talking about how to do that consultation, how to do that level of risk determination, because once those are in place, the pharmacist can probably take that ball and roll with it. But we need to have them getting that information and doing it in a way that's effective and efficient.
Thank you, Sherilyn. One of the things that strikes me as I was listening to you is that between us, between our two faculties, we are sending out many change agents. So we are educating and increasingly preparing our students to deliver these vaccines and these consults and these vaccines. Mm-hmm. In your opinion, what can we do to positively impact the uptake? Is there anything we can do to help mentor, like guided mentoring to implementation of services?
Oh, absolutely. I agree. It seems like our new grads are very entrepreneurial minded, right? They want to do new services, they want to expand. And I think that we need to capture some of that enthusiasm and that entrepreneurship before it dissipates. I think that kind of happens in practice. You get caught up in the day-to-day and maybe some of that motivation. So, I think that encouraging our students with an interest in this area to, connect them with someone who's actually doing it so they can see the process early on into their practice and start to make that a reality. Motivate them to write their CTH exam relatively quickly. Have those mentors, I think, in place that are actually doing it in practice, because I think that for us to say you have the knowledge, you have the scope to do it is a lot different than actually making it happen. So there's a handful of really, really high-performing pharmacists in Ontario and nationwide, really, who are performing travel consultations that I think if they're willing to be a mentor to those new grads and show them how to make it happen in their practice, that we can hopefully keep that excitement and that momentum moving for them.
That's great. Thank you very much. I think one of the challenges is as we prepare our students, as we better prepare our students to go into these areas of practice, what is their opportunity to continue to develop and learn once they're out there, and how can we as faculty support that through a peer mentorship model, like pharmacist to pharmacist. Thank you very much. I'd like to open it up to questions from the audience now. Thank you, Lisa.
All right, thank you.
There's two online. Is there any in the room, or should we start with one online now? Do you want to read it in?
Yes. So there are
yeah.
The first one is, do you recommend appointment-based assessments? And if so, what types of vaccinations lend themselves to walk-in care?
Yeah. Did you hear that, Sherilyn?
A little bit.
Yeah. I think I can actually put it up here. Do you recommend appointment-based assessments, and what types of vaccinations do you think lend themselves to walk-in care?
Wow, that's a great question. So that is such a fine balance, and I think we see the same balance with travel consults as we do with flu shots, in that the public values the convenience of walk-in, but it's really disruptive for the workflow for the pharmacist and their focus and their attention. So there seems to be a disconnect a bit between what the patients, value and appreciate the most and what is best for the pharmacy to deliver. So I see a lot of the pharmacists that do this on a regular basis. They will take walk-ins for very simple cases. So someone going to an all-inclusive resort in Mexico, they will take that on a walk-in, but anything more complicated than that does get an appointment. That allows for that consultation to be of sufficient duration to really look at their level of risk, to really provide that education, to really, tailor the recommendations. I think if we try to do too much too quickly, we run the risk of over-treating. I think we run the risk of recommending vaccines where a person's really at low risk of actually getting it. So I think that for our reputation as pharmacists providing evidence-based care, it's better to go with an appointment for anything more so than a healthy adult going to the Caribbean.
Great. I think we have two more follow-up questions from that as well. The first one, what is the time required for an average consultation?
All right, so most people, like our clinic, for example, and many pharmacies tend to block off about 45 to 60 minutes, but that's for the entire process. So that includes the interactive time with the patient, collecting the information, providing the education, that type of stuff. That also includes vaccine preparation and administration and documentation afterwards. Out of that 45 to 60 minutes, usually about 20 to 35 is the duration of the actual face-to-face consultation. So, you know, it's a pretty even split between the interactive and the more kind of technical or administrative aspects of things, but most people, to make sure they aren't rushed, will block at least 45 minutes start to finish for the whole process.
Okay, great. Anyone in the room with us? Any questions? Or I can take another one from online. Okay. So we also have another question from Mona. Physicians at teaching centers routinely charge for short-term learning fellowships for practicing MDs to upskill themselves. Why does this not happen in pharmacy?
I love that question and I love that opportunity. I completely agree. I've certainly heard of many pharmacists saying, I don't feel I can learn this through a written CE or an online CE or going to a single conference session. Like, I would like a couple days, a weekend, a week, whatever, to learn it more intensely. And we just don't see that available right now. And that's internationally. I was looking for it myself and I ended up going to London for a week, London, UK, to get a short course of travel medicine. And they're very hard to come by. The International Society of Travel Medicine does have a 2-day review and update course, and I completed that a couple of years ago, but it's entirely knowledge-based. It's not that practical application where they're seeing a consult start to end and actually kind of shadowing someone who's doing it. So I agree, there's a huge appetite for it. I think there's a willingness of pharmacists to pay for it. I think we just have to actually make it happen. Because it's right now probably one of the biggest barriers is we just don't have that anywhere in Canada or North America, to be honest.
Okay, thanks. I think we have a question in the room. Sorry, what's your name?
James.
From James.
In your research or history, have you found any nurse practitioners who are doing this?
Oh, great question. The question was if there's nurse practitioners who are doing this, and the answer is definitely yes. They're usually, so I would say in terms of the proportion, so let me backtrack a bit. So when you go to the ISTM conferences or whatever, there really are 3 professions that are represented. There's physicians, there's nurses, there's pharmacists. Within the nurses group, I think they are one of the larger groups. I mean, certainly they made up the bulk of people that went to this review and update course that I was at a couple of years ago. But most of them are not nurse practitioners. Most of them are registered nurses doing it under a collaborative practice agreement or delegated prescribing. So a lot of the private clinics, for example, follow that model where they have the physician overseeing the clinic and having registered nurses doing it. So I think, to be honest, there's probably more community pharmacists who are doing this than nurse practitioners, but that's strictly just observation. I don't have data to back that up. That's kind of what I said. RNs and pharmacists and family docs, and then nurses are a smaller portion of that nursing profession for sure.
Thank you. There's also a question from Lisa online. How could pharmacists and clinics work with pharmacists in community pharmacies?
Oh, that's a wonderful question too. So obviously there has to be that connection, that collaboration in place, because a lot of the clinics don't do on-site dispensing. So for example, at our clinic, we will administer vaccines on site, including the oral vaccines. We have oral typhoid vaccine on hand, but any of the other medications are dispensed by the community pharmacy. And so perhaps one of the greatest learnings I have taken from that, and I worked on the other side in the community pharmacy as well, is that the prescribers don't realize the information that we need to do our job in community pharmacy. So an example of this is that the current monograph for Alarone for malaria says it should be taken for a week after returning from travel. And that's what every guideline, every recommendation, every monograph says. But yet a lot of physicians who specialize in travel medicine, including the ones I work with, only prescribe it for 3 days after. And so the pharmacist receiving the script on the other end is conflicted because they're saying, well, I know this is a reputable, specialist in travel medicine, but they're still not prescribing according to the monograph. And it's a perfectly valid reason. There has been research showing that really you only need those 3 days to get the same benefit as 7. So there's a rationale for it. But I had that discussion with the prescriber that you need to document that. You need to tell the pharmacist why you're doing it, that it's intentional to only be 3 days. They need to know where the patient is going. So I think there's a role for pharmacists and really anybody who is working in this type of clinic environment to improve their information sharing. Even basic information about why you're doing a 3-day versus 7-day course is going to make the community pharmacist job a lot more effective.
We also have one more from Lisa. If pharmacy curriculum is all split up in terms of when students learn about vaccines, then we have gaps. So how should the curriculum advance with these new opportunities in mind?
Wow.
We're giving you some hard questions to work with.
It is. And, we've struggled with that here at Waterloo because, for example, we do our injections training in the 2nd year of the program. And because I'm kind of the coordinator of that, I force them to also learn about travel vaccines at the same time that they're learning about all of the other vaccines that are available. So I kind of make them learn that content-based knowledge in 2nd year. And then in 3rd year is when we kind of talk about in the skills lab about what a consult looks like, but we don't yet actually do it in an interactive simulated type of scenario. So I think that's really hard, and I don't know what the magic answer to that is, because a lot of curriculums don't have the capacity to do an elective or a standalone course in something that's this specialized. So I don't know if we need to, maybe tie together at the very end and remind them the principle of these things. Maybe that's a 2nd year or a final year, skills lab activity to force them to tie that together and do a consult start to finish and kind of realize they've already learned a lot of this stuff. But yeah, that's $1 million question that's going to be a little bit challenging to do. We see the same thing, for example, with students saying, I don't know how to do a meds check. Yeah, you do. You learned how to do a best possible med history. You learned how to do seamless care. You learned how to do care plans. You just don't recognize that those all get tied together into a meds check. So I think we're having the same problem with travel health right now.
I think there's actually, okay, Lisa says, no, never mind. That was her last comment on that. I actually had a quick question just about, you profiled the research coming out of Canada and the US, which was really great to just give us an overview of what's happening there. Is there any work coming out of the UK? I was kind of surprised not to see anything there just because they can prescribe.
I know that I'm equally perplexed. In fact, one of my main contacts that I'm working with on some ISTM stuff is out of the UK, and I almost think that it's a matter of there are very few researchers who are doing work in this area. So I think there's lots of practitioners, lots of clinicians, community pharmacists, things like that who are doing it, but they're doing it as a clinical service for their patients. They're not doing it with research and publication in mind. So, across Canada, there's a few people doing research in vaccination. There's not many doing research specific to travel medicine. I think that's the issue in the UK is that no one's taking that practice-based data and packaging it up into a research study and publication. I think the data is there, it's just not being utilized.
Yeah. Thank you for that.
Yeah.
Okay, I think that's all the questions we've had from online and in the room. So I don't know if there are any other thoughts from anyone or if Sandra, you have anything to close with, but I'd like to thank you for that great presentation. Thank you and Sandra.
Pleasure.
I think it was very, sorry, Sandra, you
Thank you very much, Sherilyn. It strikes me of the variation across Canada, and as a final thought, I wondered if you can comment on that. Is there anything we can do as pharmacists to contribute to this discussion nationally so that we can have more harmonization and across our provinces?
Oh, definitely. It's certainly an area that I know CPHA is looking to harmonize the scope of practice. For people that are on the front lines providing care, I mean, I always encourage them to get involved with research opportunities when they're made available to them, because without that, we really don't have evidence to help push that forward with. And I think that there's also underutilization of the existing scope available to a lot of people. So a lot of provinces have the option for delegated prescribing, but not very many pharmacists have actually pursued it. So I think the more and more we can get pharmacists to even use what they already have to its full potential, it'll be even easier to, you know, move that upwards and kind of elevate the entire country to hopefully be in line with the Alberta model.
Thank you. That's more poignant in Ontario, I think, today, in terms of if we don't make the best use of what is available to us, we have the potential to have that taken away.
Yeah, unfortunately, yeah.
I thank you for this wonderful presentation. I know I certainly have learned a lot, and want to thank you and hope we continue this conversation going forward.
Thank you.
Okay, thank you to you both, and thanks to everyone who is listening online and in the room with us. Thank you both for your insights on that topic.
Thanks.
Anytime.
Take care.
Take
Okay,
care. Bye-bye.
bye.